Good morning. This is Jocelyn Lockyer. I'm Senior Associate Dean Education and a professor at the Cumming School of Medicine, University of Calgary. Welcome you to the webinar series and recognize that for Americans this is a very big day, but also want to recognize that we have people today on the call who registered from Canada, Netherlands, Australia, Trinidad and Tobago, Denmark, the United Kingdom, Russia, Japan, Belgium, India, and the US. So a large group of people from around the world, and we're very happy to have you. The topic today is Core Principles of Assessment in Competency-Based Medical Education. This session is being run by Claire Touchie. Claire is at the Medical Council of Canada and the University of Ottawa, and myself. So welcome to today. So that you know, recording of this webinar will be on the ICRE Collaborators website within about 2 weeks, so you can listen to it. You can also access previous webinars, and you will get a short survey after the webinar to provide feedback. You should have on your screen an area to enter questions, and we encourage you to enter questions at any point, and we do really welcome questions because it helps us gauge the interest, but also some of the issues that you're all facing related to competency-based medical education and assessment. So please use the question area. We do stop periodically to address questions, and so these are very important to us. We have 2 Twitter handles, CBME Assessment and MedEd, so please feel free to Twitter during the webinar. Neither Claire or I will be following the Twitter. We figure we've got enough to do just to handle the webinar and the questions on that you're going to provide to the webinar itself, but please feel free to Twitter and have an exchange there. So just to remind you of the webinar series, we've done several. This is the 6th in a series, and next month we'll be implementing a competency-based medical education, followed by evaluating CBME programs, looking at systems challenges, and then the final one scheduled for March on competency-based continuing professional development. So a full series. Okay, so to begin what we're here for, Claire and I are focusing on the core principles of assessment. In terms of disclosures, I have nothing to disclose of a financial nature. Claire reports that she has participated in clinical trials for HIV care with multiple companies. And we are, as mentioned earlier, members of the International Competency-Based Medical Education Collaborators. In this work and our presentation today, I want to acknowledge a publication that will come out in the new year in Medical Teacher. It was a publication in which several of us, myself and Claire, but as well Carol Caraccio, Minka Chen, Danielle Hart, Sydney Smee, and Eric Holmbo got together to really think through what the principles were. And this will come out, as I mentioned, in January, as will a whole series of articles. What we want to do today is to have you think about and provide us with feedback on the principles that we've come up with. Consider the enablers and barriers that are present and needed to transform assessment approaches in your settings, and then think through the next the next steps towards optimizing assessment procedures and processes. So a big bundle for an hour. So to give you some background, I mentioned that there was an international collaborators group of about 30 people. And our goal was to reconceptualize and update competency-based medical education. Some of you will remember the medical teachers series that was published in 2010. And from that, we've had some outcomes, the big outcomes still to come in the medical teacher series, but an article published, two articles actually published in Academic Medicine, one led by Carol Caraccio, the other led by Ola Tankata. So you can certainly look for those and read the charter and about entrustment decision making. The group also hosted the World Summit in Barcelona in 2016. So quite a bit of work has been done and conceptualized as we all move forward with competency-based medical education. So I think it's important to review the definitions that are core to competency-based medical education. These came out of publications in CanMed, and they were also described in the session that Ola Tankata gave a few weeks ago. But remember, competency-based medical education is an approach to designing medical training focused on outcomes in the form of abilities of graduates. And abilities is the operant word. So really think it through abilities and outcomes. Competencies are an observable ability of a healthcare professional that develops through stages of expertise from novice to master. Entrustable professional activities are essential tasks of a discipline, that is the profession, a specialty, or a subspecialty that an individual can be trusted to perform without direct supervision once they have achieved competence. So it's not that they've once got there, but they've demonstrated competence over time. Milestones, on the other hand, are what you'd expect and what you see with children as they develop. It's defined observable markers along a developmental continuum. So while the EPA, or entrustable professional activity, is the terminal point, milestones are core things that happen along in the way of or in the process of getting to the entrustable professional activity. I remind you that this is not unique to medicine. It's important in primary, secondary, and post-secondary institutions. It's particularly important as people recognize that there are important accountabilities. And there's a great movement to observable, transparent, and measurable outcomes. And just to expand on that a little bit, the Sturgis report, and that's STURGIS report called Reaching the Tipping Point, Insights on Advancing Competency Education in New England, has just completed a major report on competency-based education in the kindergarten to grade 12 era. And it summarizes why in high school and public school education, people are examining and adopting competency-based education. And some of the core concepts are that it enables schools to move away from time-based curriculum, because in a time-based curriculum, often students will accumulate gaps in knowledge and yet move along, but they still don't have the fundamentals of reading, mathematics in order to be doing higher level, and so the gap and disillusionment continues. What it does also, though, is it focuses on intrinsic motivation, not extrinsic. So instead of the scores that are externally set and being the marker, in this case, it's an intrinsic marker. It's what you yourself can do from within that gets you along the way with support and help. It's also noted that competency-based education overcomes some of the high variability in how teachers determine proficiency, because it's much more standardized, but it involves teacher training. And it overcomes the messiness of learning, recognizing that people learn at different levels, but also they bring different skills and life experiences. And and with competency-based education, you can organize things around the learner and not so much around the teacher, schools, and efficiency. And so with competency-based education, students will advance upon demonstrated mastery. The competencies include explicit, measurable, transferable learning objectives that empower the students. Assessment becomes meaningful and a positive learning experience. The students receive timely, differentiated support, and the learning outcomes emphasize competencies that include the application and creation of knowledge along with the development of skills and abilities. So that's why the tide has turned in school kid education, and by the same token, it has also changed in health professions education as we look for accountability to the profession, to the employer, and society, and recognize that we need to be much more explicit about the abilities of professions within their own discipline, as well as their ability to function in workplaces that want inter and intra-professional collaboration and professional practice. So in competency-based medical education, there's two core concepts. This is not the principles, but this is the core concepts. And the concepts are of learning and for learning. So in for learning, we're thinking about whether the learner is progressing. Are they ready to progress to the next level? So that's about for learning. Of learning is, did they get there? Did they make progress against targeted outcomes and criterion reference standards? So as we think about it, in the past, we really focused on of learning. But as we think about for learning and moving people along, we recognize that formative feedback is critical to be able to get to of learning. Assessment has utility because assessment drives learning. In fact, there's some interesting research which suggests that you could give up a lecture and add an assessment or a test, and you'd be further along in terms of student learning. But assessment has to be integrated in a routine so that it becomes regarded as indispensable, much in the way that a golf coach or a violin teacher handles progress. So if our primary purpose in assessment is to drive learning, and our secondary purpose is to make judgments, we really have to be developing assessment systems that are based on fitness for purpose. And so we then think about assessment for learning, because that also has to align with the principles of competency-based medical education, including active involvement of the trainee in driving learning and assessment, creating authentic environments, using direct observation and emphasizing formative feedback. The concept of learning aligns with a focus on targeted outcomes, multiple assessors using multiple methods, and criterion reference standards. So in the end, what we're trying to do is figure out how big is the risk of how big is the risk that the student is performing below the standard in a future case, given the history of the current observation. And so we want to maximize the probability that physicians graduating from residency training can provide safe, effective, patient-centered care. So that's our goal. So thinking about for learning and of learning. I think Kees van der Vleuten states it best when he said, whenever assessment becomes a goal in itself, it's trivialized and will ultimately be abandoned. Assessment has utility insofar as it succeeds in driving learning, is integrated in a routine, and ultimately comes to be regarded as indispensable to the learning practice. So let's look at for learning, which involves the learner, and some of the ways we look at for learning. And you can see we've got the Miller pyramid without it being in a triangle. But if you think about for learning, the way we assess whether somebody knows something, we use multiple choice questions, short answer tests. In terms of whether they know how, we think about written assessments, oral questioning, the learning plan. Showing involves simulation, OSCEs, oral cases, and in the doing, that's where we get to things like direct observation, end of rotation evaluations, case logs, multi-source feedback, product reviews, such as how well people do on laceration repairs, and patient outcomes. So you can see that the for learning has many, many options and many approaches. When we think about of learning and recognizing that this is terminal, or at least summative, not terminal, but summative, here we also recognize that we need to move away from assessing the learner in terms of only their medical expertise, but into other aspects of CanMed's ACGME competencies, good medical practice. Also thinking through what the current healthcare system expects, and that is patient care that's aligned with the best practices in precision medicine, teamwork, patient safety, and population health. So questions, and I see the first question on the board is to restate the reference relating to the K-12 work. Yes, and the author is Sturgis, S-T-U-R-G-I-S, and the report, which comes out in New England in 2016, is called Reaching the Tipping Point, Insights on Advancing Competency Education in New England. And if you type in Sturgis and Tipping Point, Advancing Competency Education, I think you'll get to it. Other questions?
Shall we move on, Jocelyn?
Yeah.
Good morning, everyone. I'm Claire Touchie. Excuse me. I'm the Chief Medical Education Advisor for the Medical Council of Canada, and I'm an Associate Professor at the University of Ottawa. and I'd like to welcome everyone to the webinar this morning. Following on what Jocelyn has spoken about, we're going to move on to the core principles that we suggest for a competency-based medical education program. There are 5 principles that our group came up with, and we certainly would love to hear if you think there are more principles that we should consider. The first principle is talking about a timely ongoing assessment with comprehensive periodic reviews to ensure continued progress. And I will go into more details on these core principles in the next few slides. The second one is how do you best use your assessors, and the fact that there needs to be multiple assessors when you consider these assessments to make sure that you enable the right assessments to be made at the right time for the right purpose, while avoiding assessor fatigue. I think that that's going to be a great concern for for systems, is ensuring that we don't drive our assessors into the ground. The third principle is mechanism to synthesize data that's collected through group processes and to reach judgments about competence. It means that we have to look at our psychometrics a little bit differently. Faculty development is key as a principle for all our assessors who, as observers of trainees in the workplace, are the true measurement instrument. We have multiple tools out there, but really our core tool are the assessors who do the observations. The fifth principle is to optimize the relationship between the givers and receivers of formative feedback to enhance the incorporation of the feedback into practice. So as Jocelyn mentioned, when we talk of assessment for learning, the feedback is a key point in the learning experience, and to make sure that the student or the resident keeps moving forward. Next slide, Jocelyn.
Yep. Oh, I think you have to do it.
Oh, do I have to take over?
Oh, there it is.
So when we talk about multiple methods, we need to make sure that the collection of data is purposeful. I think that this is key. We need to know why we are collecting the data. We need to make sure that we have some structured measure, that we know that there will be assessments throughout time. There might be some assessments, some collection of data that is done for learning itself, and some of learning. There will be some that are done along the way with very low stakes, with some small bits of observations done on a regular basis with regular feedback. And then there might be these periods where assessment is done in a much more structured fashion with a higher stake, higher output examination, for example, the national boards or the an outcome certification exam. I think that we've been, no, stay on the same slide, thank you. The quantitative and qualitative data are going to be needed to add to the meaning and trustworthiness or validity of your assessment. We've been focused a lot on quantitative data. It is very difficult to give meaningful feedback when we're dealing with numbers. The difference between a 4.5 and a 4.7 on a 5-point scale is fairly meaningless to the candidate or to the trainee, as opposed to qualitative data. We are starting to understand how to use qualitative data, but and the fact that it can really add meaning to our assessment. The other fact when we talk about multiple methods, no single method can assess everything that we want to assess. Multiple choice exams are extremely reliable. They can meet many of the criteria of validity and are very useful to assess knowledge or application of knowledge, but they are certainly not useful if we think of the other things we want to measure, such as the non-medical expert type of competencies that we look at. And therefore we need to put multiple methods together to be able to get a whole picture and to compensate for those shortcomings. Next slide. You also need multiple assessors. So in order to be fair to the candidates, the residents, the students, you need to ensure that they get multiple points of view. This will help compensate for possible biases, possible halo effects, or possible leniencies, or I guess the opposite of leniencies, which would be stringentness, if they encounter an assessor who had a bad experience with them or who had a wonderful experience with them. They may have intrinsic biases that will lead to a decision that's less than perfect. So having those multiple assessors look at them from different points of view is very useful. You may have rate or judgment issues, as mentioned before, which can cause your ratings to go one way or another for reasons that are other than just the behaviors or the performance that you're watching. Multiple assessors also provide multiple biopsies, and we know in assessment that the more biopsies that you have, the more you might be able to see the picture of who this person is and be able to assess the whole or be able to predict what their knowledge, skills and attitudes really are and predict how they're going to perform in the future. Next slide. I think that assessor selection and training, when we talk about faculty development of assessors, I think that this is going to be a key issue in assessment in CBME, and certainly is one of the issues that is being worked on and is being reported on quite a bit, especially in the last year in the literature. The goals, when you look at assessor selection and training, many people are now starting to think that maybe it's not all of our clinicians that should become assessors, that maybe some are more suited to this type of role than others. You need to make sure, and reasons for this is that they do need to be knowledgeable and trained at what they are doing. So we need to make sure that the goals of assuring that the knowledge of competencies that are being assessed, they need to understand what it is that they're looking for. They have to have an understanding of what they need to observe, and they need to understand how to record that observation. They need to have a shared mental model of what it is that they are to address and to look after. So that takes quite a bit of training, the same way that you develop a shared mental model of what type 2 diabetes is and how to diagnose it and how to treat it. I think you need to have a shared mental model of what a pediatrician looks like throughout the continuum of their training. We need to understand that this training is not something that is going to be done automatically by handing a tool over. As simple as that tool is, we need to make sure that there is integrated training. It's not just a one-off. It's not a 15 minutes of here's a card, here's how you do it. The integrated training needs to be ongoing, it needs to be deliberate, and it needs to be practiced. So there are ways of doing that. It requires intensity, and that's why that some schools have gone to certain people as being expert assessors that are actually being paid to do the job that they do, so that they can continue getting the training that's ongoing. And maybe with time we will be able to train all of our clinicians, but I think we need to be thoughtful about how we do that training. There are some techniques out there for training. Jennifer Kogan and her colleagues did publish a paper in 2014 looking at some of those techniques for training. Three of them that they report on are behavioral observation training. So if you think of understanding the observation processes, what is it that you're observing, and creating training so that you improve those observations. So knowing what it is they're supposed to do, understanding what it is they're supposed to do, and understanding how you're supposed to rate them. There's also performance dimension training, which is learning and applying the behavioral criteria and standards for competency. So really making sure that you have a shared mental model, and you can do that with video training, making sure that you understand that which point of view you're seeing it from. Many a times we're comparing them to what we think we should be, as opposed to understanding the criterion for which we are assessing them for. Finally, there's frame of reference training, which again, you can use videos, and often you use performance dimension training at the same time, where you align your assessor judgment with a common criterion-based frame of reference. So that you would watch a video where you see a candidate perform, and you would rate, and then you would have a discussion, sort of like a standard setting exercise, and you would come to an agreement that this is a good or a bad performance, and that everyone would leave the room feeling that they're on the same level. So you need to make sure that your training and your assessor selection is purposeful and also strategic. Next slide. And I see that there are questions coming in. We'll get to the questions when I finish this section, and we will answer as we go along. Psychometrics. I think that some of this will require some reconceptualization of psychometrics. John Orsini and his colleagues published in 2011 what good assessment programs are characterized by. So not only do they need to be valid or coherent or trustworthy and reliable or reproducible and consistent, but we need to be able to demonstrate some equivalence, so that somebody who is being assessed in one setting is not being unfairly distinguished from somebody else who's being assessed in a different setting. We need to make sure that this is feasible, and I think that that's probably one of our biggest hurdle at this point, is looking at the feasibility. Acceptability, we certainly are seeing that many people are starting to accept the way forward with CBME, but there are still quite a few that are not accepting this at this point and not seeing the evidence for it. We need to make sure that there's educational effect, so going to the outcomes-based CBME, making sure that we are actually creating an educational, that the assessments that we're creating do enhance the education the way we want it to, and that they're not just jumping over our hurdles for hurdles' sake and not for outcome's sake. And finally, there should be a catalytic effect, in that I think it should, there should be a hoop between, or a loop between learning and assessment. Next slide. So in this kind of case, we're talking about optimal assessment of individuals, and we have not gotten into the assessment of teams or of systems, but certainly of the individual requires an accumulation of evidence. So just as in a test using multiple choice questions, you don't have the question that's going to answer all your that's going to provide all the evidence. You need multiple questions to be able to do it. In a competency-based medical education program of assessment, you will need evidence on the basis of methods and tools that support the decision to be made. So you need to have workplace-based assessment, you need to have assessment of knowledge, and you need to have assessment of skills. You need to determine the judgments to be made. How are you going to judge the competencies, the EPAs, the milestones? What evidence are you going to use that's going to support your judgment? Data needs to be collecting using appropriate sampling with multiple methods. What are the abilities and development of faculty member? How are you going to make sure that they can use the tools appropriate? And you need to make sure that they can assess the learners and provide feedback on their performance. I think one of the questions and one of the psychometric fact that we need to look at is that workplace-based assessment is a messy world. I think we have a good handle on tests of knowledge. We have a fairly good handle on tests of skills using instruments such as simulation or OSCEs. But when it comes to workplace-based assessment, with the psychometrics that we have right now, we see a huge amount of variance in assessor ratings. And I think that we need to be cognizant that that variance is not all attributable to error. I think that some of the variance reflects the fact that they look from different lenses and the way that they see the learner, and that variance is not a bad thing. That variance can actually paint a picture. The importance will be to ensure that we have enough of those snapshots to be able to paint a proper picture and not to bias our results. Next slide. Finally, when we look at CBME and assessment, we need to think of the group process. All these individual observations need to be put together. We know that the wisdom of crowds recognize that no combination of assessors and assessment methods can measure all things. But we need to be able to make sure that the wisdom of crowds, that we're able to synthesize that data, that deficiencies are often only identified in group evaluations, so that we might be seeing some behaviors that look kind of okay on an individual basis, but you start seeing a full picture with little things cropping up. For example, if they have communication issues, it might be through multiple observations that you're able to nail that down. The critical importance of assessment committees in synthesizing data and reaching summative judgments. I think we're starting to see either some committees that are coming together with those multiple data points. Recent paper just published in the last couple of weeks by Eric Worm shows that gathering thousands of data points shows a picture that is starting to emerge that makes the job of committees that are doing these, that are assessing these competencies, it's making their job a lot easier to be able to see a picture of somebody who is performing as expected or somebody who has clear deficiencies. Next slide. So in summary, the principles look at multiple methods, multiple assessors, selection and training of assessors, reconceptualizing psychometrics and how we put the data together, and finally group processes to reach those critical summative decisions about competence. And I'll stop here to take some questions. Jocelyn, I'll read them out loud and we can see which one of us answers. So Denise writes, what do you think the key issues or skill is that all clinical teachers should focus on the transition to CBME? Good question. I think I'm going to try and attack this one, Jocelyn. The key, I think that, so one of my question is, do all clinical teachers need to focus on the transition to CBME, or do you have champions? It's a tough call when you're looking at busy clinical services. I'm a general internist, and when you look at very busy teaching services with multiple sick patients, do you need to train all of the clinical teachers? So the key issue to me would be to look at what it is they're already observing. What is it that in their daily work are they observing with the trainees, and can we get them to report on that as a starter? So I would start with the small chunks that way, and then seeing where the gaps are in our assessments. But making sure that they learn how to report, and we will need to train them how to report those observations that they already make.
This is Jocelyn. I would support that. I would also say that we have some good examples in family medicine in Canada, areas like anesthesia, the daily encounter sheets. They come by various names, field notes. And if you can get faculty members or preceptors to report on a daily basis, in addition to what would come out of a bi-monthly or end of rotation evaluation, I think then your committees have much more to work with. So trying to keep it simple but consistent and an expectation, but also ensuring that people get some feedback on the data that they provide about the learner.
I see a question that states that when I stated that all faculty are not going to be assessors, whether I was talking about assessment of learning or assessment for learning. Some schools are looking at even assessment for learning, of developing some master assessors. I can give an example of, for example, at Vanderbilt, in their undergraduate program, they have trained expert assessors. So that even for assessment for learning, they have expert assessors that come and do those types of assessment with the students. There are some schools, for example, in the Netherlands, who have trained every one of their faculty members. So I think there are variances, and I think it depends on your philosophy. And I think it depends on the type of service that you're on. And the type of learning environment that you're on. So I don't think that there's a single solution for that one. The next question, when we talk about assessor training and rating, do you recommend certifying them through workshops, etc., before they start their observation? Jocelyn, do you want to take that one?
Well, I'm not a... I would normally say that all faculty should have some training in how to do this. The devil, I guess, is in the details. We have in our school something like 2,500 clinical faculty who could be involved. It's a bit of a daunting task to think through that. I'm not sure certification per se is going to happen. I think it's a laudable goal. But I do think some training and training on how to use the tools and to get some calibration there. And that can be done reasonably easily with small groups of people, but you do have to look for opportunities such as rounds and grand rounds, education retreats, in order to do that in a focused way. So maybe not a certificate, but certainly training. Maybe ultimately a certificate if that's what your environment will support.
I think there's a question by Donna Ray, which is an interesting one. Are you aware of any studies that show the value of group assessment and prevent groupthink or the skewing that might occur with an outspoken team member? In other words, effective teams for effective assessment results. Work-based assessment is done widely in business. What lessons might they give us? I don't know of any paper right now that looks at whether or not there's skewing that might occur with outspoken team members. There are some papers starting to come out on competency committees and how they work. There are various structures for competence committees, so some are including residents, including sometimes the resident that you're assessing in the competence committees. So I think there are different ways that you could probably mitigate that, making sure that there is somebody who is speaking on behalf of the resident, making sure that the chair is trained appropriately to ensure that there's not an outspoken team member and that there's sufficient numbers on that committee to make sure that it's not improperly skewed. Jocelyn, do you know anything about the business world and workplace-based assessment?
I don't know that literature. I would say that one of the things the chair does have to do, though, is focus on the content of the assessments, because you're right, it is easy to get derailed into issues of personality and things that maybe are tangential to the assessment, and that what you really want to be focusing on is the forms and questionnaires and daily encounter sheets, field notes, whatever there is on that trainee to provide as broad a discussion so that the committee sticks to the facts. Although I don't deny the importance of a group of people getting together all with concerns that they might describe as modest concerns about a trainee who slips out early, doesn't take responsibility, and it's only when you really talk about the trainee that you do get a picture that maybe there is issues of professionalism. So it is a double-edged sword for sure.
I think that we should probably move on, and if we have time, we'll address some of the further concerns. Jocelyn, I'll ask you to move to the next slide. I think that there are some realities that we need to take into account when we talk about moving to CBME. There are some opportunities and some challenges that we need to take head on. The fact that there are broad and diverse competencies that need to be assessed. We're quite good at assessing the medical expert role, or the way that we make diagnoses and the way that we make treatment plans. But I think that there are some areas where we are still working on to see how we're going to assess. How do we assess teams, and how do we assess how somebody functions in a system is still not completely clear. We still have some issues with assessing professionalism, and that has come to bear through studies that I don't think we have that quite right yet, and whether or not as we move into workplace-based assessment we have a better grasp on that. we will see. Faculty development strategies are still needed, and many of our questions point to that, and in that these are difficult to plan, they are difficult to execute, it's difficult to get buy-in from very busy faculty, and to see how this will sort of chew into some of their time. We need to enhance the quality of the assessments, and we need to ensure learner progress is adequately sampled, so that the reliability of expert judgment is enhanced. So those are going to be, I think, faculty development will be a challenge for us from that perspective. Next slide. Another challenge and a great opportunity, I think, is the information management and documentation. Those that have gone to technology, technology can certainly prompt reflection on performance at the individual and program level, so that you can have tools on your handheld device that can help you while you're chatting with the resident about the performance, that can help you reflect and can help the resident reflect, but also can provide information for program evaluation, in that you can see deficiencies in your program at a fairly comprehensive level as you gather information. These systems can inform progression decision as well as other important judgment about learners. It can also show the learner how they are progressing and where some of their areas of deficiencies or the lacunes are. It also can create some fairly comprehensive dashboards to compare not only the individual and the different competencies that they are achieving or that they are not achieving, but it can also show them you can compare them to a reference group to stimulate some reflection on learning, their needs, their gaps. It can also show the program where there may be some gaps as well. So the information management and documentation, although as nice as it might look, these are they're labor intensive to get up and going. They are financially challenging to get up and going, and they are resource intensive. So I think that will pose many a program some challenges as we move forward, and the hope is that people can share. Next slide. The documentation considerations are significant. The audibility to provide validity evidence. So with the massive amount of documentations that can occur both from a quantitative and qualitative, these provide evidence to support the progress of the learner. It provides validity evidence by documenting your processes and supporting the outcome in your decisions. The documentation will also provide transparency to make those clear decisions and to make sure that if other people were to look at that evidence, they could make the same decisions. And it also provides accountability to assure both the learner and the health system that the learner is progressing adequately. Finally, Jocelyn, the next slide. So when we talk about improving the assessment system, changes in the system must ensure that there's ongoing learner assessment, and that the information from one phase to another is moved with the learner, so that the learner can focus on gaps and build on strength and not start over every time they go from one phase to another. The changes in the program must ensure as well that there's ongoing program evaluation, in that aggregation of data from multiple trainees can determine whether a cohort can reach desired level of competence. Did we get our outcomes right? Is there something we're not doing that we should be doing? as we look at the trainees that have gone through. And we have to remember that outcomes should drive the process. We must, as we do this, meet the patient or the societal needs. So it needs to be designed with patient and patient safety in mind. We tend to focus, although this is a learner-focused system, we need to remember what the original premise was, is that this is actually based on meeting patient and societal needs. So in summary, CBME relies on a program of assessment that includes multiple methods and multiple assessors and is embedded within an effective educational system. So it really is a loop. Assessment for learning plays a prominent role in CBME since formative feedback is an essential element of developing competence. So it's that assessment for learning that is important. Faculty development to create a shared mental model of required learner behavior and expected levels of performance is foundational to CBME. So we need to figure out how to develop the faculties that we need to develop, and we need to make sure that they have shared mental models of the learners and which behaviors we're looking for. We need to accept that variance in assessor rating is not all attributable to error, but that some of that variance just reflects a different lens through which an assessor sees a learner. We also need to make sure that the assessment instrument, that we understand that this is primarily the individual who conducts the assessment rather than the tools or the forms that they use. As such, the individuals using assessment tools and forms need training, so getting back again to faculty development. With that, we'll address other questions that people might have in the 3 minutes that we have left. So one of the questions from Cecil Robinson asks, can you provide examples of schools that are doing CBME well-documented CBME curriculum, assessment, and faculty development? From my perspective, one of the schools that I think is doing this well, I think that in Canada, the family medicine programs who have been doing CBME now for multiple years, some of the schools are doing this exceptionally well. One of the schools that I've done some work with is the University of Alberta, and I think that they've been able to develop a curriculum, an assessment strategy and faculty development that's worked well. It's been labor intensive, it's been ongoing for 7 years, but I think that they're starting to see some ability to be able to detect issues earlier and rectify them. Jocelyn, any comments on that?
No, I think in Canada, family medicine is the furthest along. Queen's is working hard to develop their programs to implement fully in July, and so they'll be a good example. Of course, orthopedic surgery in Toronto has also been at it for a long time. I don't know American programs though.
There are some in the undergrad world. Vanderbilt is doing their class of 2019 is going to CBME. University of Minnesota in their pediatric world is moving people from undergrad to postgrad in CBME. Now these are pilot projects, so it's a small number of candidates. Memorial University of Newfoundland and Labrador, its undergrad program has gone to a EPA-based clerkship, and that seems to be going well. So those are the issues. Just quickly, I'd love to address Denise Richardson was wondering about dropping in the expert assessors and wondering if the principles of what is being done on a usual basis would be sort of ruptured if you brought in an expert assessors. I think these expert assessors are actually embedded in the work world. It's just that not all attending physicians are trained. As a reminder, so we'd like to thank you for participating in this webinar. And as a reminder of our webinar series, the next webinar next month will be implementing CBME, so we invite you to join us for this webinar. And we'd like to thank you for your participation. A reminder that the recordings will be available on the ICBME Collaborators site within 2 weeks, and you will receive a link to a short survey after the webinar. Thank you.